Hello everyone, I'm Dr. Santosh Kumar. I'm a consultant nephrologist in a transplant physician in Kamini LB Nagar. So today's topic is actually understanding CKD and its classical symptoms, what patients should not ignore. So what do you mean by saying chronic kidney disease? Should we be aware of chronic kidney disease and what is the percentage of it? That's very important. Worldwide, if you were to see, the chronic kidney disease affects almost 11% of the adults worldwide and almost 15.7% of Indian population. It's slightly more in the tropical region. The reason being multiple other issues are present. Sometimes it might be genetic reasons, or sometimes it might be because of the some sort of renal calculi which might be present. Renal stones are more common in tropical areas, so that's the reason it's slightly on the higher term. Apart from that, even herbal medicine intake, the type of medicine intake which is there, so based on that, it can be present. They can have it. So it's basically a long-term kidney long-term condition wherein the kidneys function at a lower level and they gradually lose their ability to function properly. So how do we define? So definition is actually based on chronic kidney disease is based on either there should be some abnormality in the function or the structure of the kidney, or there should be some sort of abnormality within the complete urine examination. It should be present, or the GFR should have dropped down, kidney functioning should have also start dropping down. That should not happen only one time. It should be you should be able to notice that drop or all these abnormalities over a period of at least 3 months. If you have to see at least over a period of 3 months, then we can identify that patient has chronic kidney disease. And you can identify based on some other abnormalities also, some other tests which are present, which can based on that also you can identify. The type of tests which can be used are one thing is you can go ahead for testing whether protein loss is happening in the urine or not. And you can also have some sort of urinary sediments abnormality or complete urine examination. There might be some amount of hematuria, blood in the urine can be present, or you can have even protein loss in the urine can also be present. So multiple this can be present, or sometimes even electrolyte abnormalities can be present, or there might be if the patient had, let's say you have undergone, patient had undergone some sort of biopsy, and biopsy shows that there is some amount of kidney damage in the tissue sample itself, then it can be present, or structural changes or imaging wise, if you were to notice some changes, that can also be present. So imaging wise changes are, let's say some cysts are present, or the kidney size are slightly in the lower side, or there might be a lot of cysts and the kidneys are enlarged, or single kidney might be present, or sometimes dual abnormal kidneys might be present. There might be scarring on the kidneys. So these are also suggestive of saying that patient has a chronic kidney disease. So yeah, apart from this, you should have a decrease in the GFR as well. And even in the history of kidney transplantation, though they have a single kidney, the transplant kidney which is working properly, even them, you can call them as, you need to call them as chronic kidney disease. So to diagnose, what do we do? The simple tests which are present is to go ahead for renal function test, which is nothing but blood urea and serum creatinine. Along with it, we also go ahead for urine test, complete urine examination. We need to get it done to check whether protein loss is happening or hematuria is there or not. And apart from that, we also check whether protein loss is there in the urination, urine albuminuria or proteinuria is present or not. That also we checked. So how is it basically divided? So KD-GLUE basically divides based on the type of GFR drop which is there. So the stage 1 is if the GFR is more than 90, and there should be, as I said, there should be some other abnormality can be present, or stage, and the second stage, the kidney has started slightly failing down. So GFR is somewhere in 60 to less than 90%, like 90 ml of GFR ml per minute. It should be present. Or stage 3, if stage 3 is again divided into two types, one is 3A and 3B, because most of the patients who have CKD, they present in this stage only. So 3A is if the functioning has dropped down to less than 60, but more than 45. And stage 3B is if it has dropped down to such an extent that the GFR has dropped down to more than 30, but less than 45. If the GFR is so level, you can call it a stage 3B. Apart from that, you can also have, if the kidney functioning has dropped down to less than 30%, but still the functioning is, GFR is more than 15%, we call it stage 4. Stage 5 is nothing but if the functioning has dropped down to less than 15%. So what are all the manifestations which can be present? So most of the times, if it's early stages, the stages which we talked about, if those stages are already present, then what happens is you don't see a lot of changes, a lot of symptoms which are present. So symptoms basically get masked by the primary disease of the kidney, which is there. Primary disease which is present. If let's say patient is having hypertension or patient has diabetes, then what happens is those take the symptoms are more related to diabetes and hypertension rather than chronic kidney disease itself. But as the kidney disease starts progressing, then you can start noticing few other changes. Like if the patient is already hypertensive, you start noticing that BP starts increasing. In spite of taking a good dose and properly following all the medications, the patient starts noting that his BP has started increasing. That you can see. Or if the patient is a diabetic, patients might notice that their sugars have started coming under control recently, in spite of being on a previously, though it was on the higher side, recently they would have started decreasing, or sometimes they might have presented with even low sugars as well. Apart from that, if to divide chronic kidney disease, you can have either chronic glomerulonephritis, wherein you have a lot of protein loss, or chronic interstitial nephritis, wherein you have a lot of uh, you don't have a lot of protein loss, but the kidney starts functioning at a lower level. So these two type of diseases vary in a very different way. Most of the times, chronic kidney disease, those people who have those sort of diseases where you have a lot of protein loss, they'll have a lot of swellings. They'll have abnormality in the urination. There might be either decrease in urination, or sometimes the urine might change. The proturia can be present. Protein loss in the urine causes these kind of things. Or if protein loss is severe enough, then you can also have swelling, which is usually starts in the either in the, around the eyes or the feet and ankles, and then gradually it starts increasing. So apart from that, what happens is you can, if the swelling keeps on increasing, then patient might feel short of breath, or if the creatinine keeps on increasing gradually, then patient might also have loss of appetite, nausea, vomiting. Muscle cramps can be present because kidney is known to produce vitamin D. So sometimes even phosphorus also starts increasing. Then you have something called as PTH, which increases. So all these changes can cause some amount of bone damage as well. Apart from that, there is significant pruritus which happens, that is itching of the skin, which keeps on increasing. So the various factors which can actually contribute to chronic kidney disease are diabetes and high blood pressure. There might be family history. Sometimes based on age also, the GFR starts dropping down. If the obese individuals are present for them, also they can have obesity itself can lead to diabetes and hypertension. Sometimes severe obesity can also cause glomerulopathy, or CKD itself can cause, and even smoking is known to cause chronic kidney disease. So what is to be done is you need to identify whether chronic kidney disease is present or not, and based on that, you need to identify by how you can start taking proper steps to reduce the chronic kidney disease progression. So most of the times, as I said, in early stages, it is usually non-specific symptoms are present. Later stages only, patient will start having symptoms. So what do we do? The basic thing is patients should be educated about what are all the things which can be present, and to take care of their basic disease, which is very important. The comorbidities which are present, they need to be treated up properly. So more, as I said, hypertension and diabetes contribute to almost 50% of the chronic kidney disease in India. So if we were to control these two, probably the chronic kidney disease will also start coming down. It's not that patients, if you ask most of the patients, they'll say that I'm taking tablets. That is not important enough. That's not good enough. Most of the times, what happens is even if you started tablets, whether they're continuing it properly or not, compliance is properly present or not, that is important. At the same time, whether patients have been taking it properly, and whether the disease is under control. In the sense, pressure should be well under control, or diabetes should be well under control. Then only we can say that patient has good control of the comorbidities. Otherwise, if you ask them, they'll say that I'm taking this tablet. What is the level of sugar control? The patients will not have an idea. They'll just remember, or they might not have been. educated properly about what is BP or what is hypertension, how should be it kept under control. Those things sometimes the higher chance it might be solved. So why is it we are worried about chronic kidney disease? So long-standing what happens is chronic kidney disease can have other problems as well. That is cardiovascular disease can increase. It can also cause anemia and bone and mineral disorders. That the bones can get they start becoming more and more weak. Fluid retention starts up. Then gradually the electrolyte abnormality starts up. There is also because of the raise in urea and creatinine or other impurities which keep on presenting in the blood, they cause a kind of dysfunction in the WBC. So that's the reason they're slightly more risk, and there are higher risk of infection when compared to a general population. Apart from that, if they have a lot of fluid retention, they can also have shortness of breath. Sometimes sleep disturbances can be present. So these are all the things which can be present. So upon all these, increase the morbidity of the patients, and gradually their lifestyle also their quality of life also starts coming. So what do we do to manage chronic kidney disease and reduce the risk of chronic? Some of the essential steps which we are supposed to do are regular monitoring is very important. So surveillance is very important. In a sense, you need to recheck or repeatedly check, or every annually you need to tell the patients who are diabetic and hypertensive to check their GFR and to see whether proteinuria is increasing or not. And once it reaches to a stage three or so, it's always better to refer to a specialist so that they can follow it up properly. So, 3 GFR, stage 3 CKD. What do you mean by that? So, stage 3 CKD means that for probably a younger person, it might be somewhere near 2 creatinine to 2.5 creatinine. But elderly individuals, if the creatinine has increased to somewhere near 1.5 or 2, then also the GFR CKD stage is almost up to third stage. The main culprits which are there are hypertension and diabetes, which has to be which we have to go ahead with controlling properly by using of appropriate medications and then monitoring regularly to see whether it is under control or not. And as I said, there are some complications which can increase with the CKD. So you need to manage anemia, the electrolyte abnormalities which are present. Those things also need to be treated up. Either patient might require an dietary supplementation if they are going on losing weight, because most of the times will be advising them to go ahead for some sort of low protein diet, or sometimes if iron deficiency might be present, you need to supplement iron either IV or oral and treat them with even erythropoietin stimulating agents as well. Apart from that, the missed thing which is very commonly present most of the times I notice most of my patients whom I have seen is that their functioning of the kidney. So most of the times more people are worried about diabetes and hypertension, and they fail to address the bone health. So bone health, what happens is phosphorus keeps on accumulating inside. That tends to cause calcium imbalances. Then gradually the bone starts becoming more and more weak. Either it can be a hyperdynamic type of bone, or it could be a hypodynamic or adynamic type of bone can be present. Then you need to also educate the patient about lifestyle changes. The lifestyle changes being either you have to tell them to go ahead for regular exercise. So smoking cessation should be done, and a balanced diet has to be controlled. Balanced diet has to be followed properly. See that they have adequate fruits or at least vegetables. The fiber-rich diet should be always present. When coming to fruits, we should always remember that most of the chronic kidney disease patients do have some amount of hyperkalemia. High potassium will also be present. So we need to again remember whether the type of diet which they are following or the type of salt which they are taking, if it contributes to hyperkalemia, that itself is a very detrimental to their health in a long term. So advanced cases, if the patient requires CKD, if the patient, let's say, you should need to advise patients that if the GFR keeps on dropping down, it's always better to consult a specialist. And in those cases who require either dialysis or kidney transplant, if the GFR is dropped down to such an extent that kidney is not at all able to supplement the body properly, or it's not able to support the body properly, in those events, kidney dialysis would be always better. And if there is no, if there is an option of going ahead for transplant, pre-dialysis itself, we can go ahead. So that's called preemptive transplantation. That would be still better. So what we tell most of our patients is at least check your EGFR, that is RFT, creatinine, and protein loss in the urine at least annually once chronic kidney disease is diagnosed. Or sometimes it can be that patient might be having some sort of or they have slightly raised creatinine. For those individuals, we usually advise them to go ahead for at least biannually. So 2 times per month also can be done. And generally, what I tell my patients is, if let's say they have very high risk, that is GFR increase or drop down to somewhere near 30% or less. So if they are falling somewhere near stage 4 CKD, in those individuals, I tell them follow monthly, recheck your RFTs regularly. A monthly wise also you need to recheck. So what are all the symptoms which can be present? So early detection, as I said, we need to explain to the patients again what are all the symptoms which can present. Most times early detection is a thing. So you keep on checking regularly, doing the test, and you can identify whether the patient is having some sort of chronic disease or not. Probably they'll take a better treatment. Or complication prevention is also one of the things. Complication prevention is nothing but monitoring of the symptoms, any change in the urination, and if let's say patient has started developing some sort of fluid overload or electrolyte imbalances or anemia is there, in those events we have to go ahead and so based on these, if the patient starts developing these complications, we can start treating them accordingly. Most of the times, if the patient has either hyperkalemia or they have volume overload, they have decreased urine output, their pressures are not under control. Most of the times, we start them on diuretics. And diuretics, what happens is uh, hydrochlorothiazide or thiazide group of diuretics are very mild. So as the GFR starts dropping down, the response will not be so adequate. So that's the reason we go for high ceiling diuretics, nothing but torsemide or furosemide. So again, we need to change the treatment of the patient. We need to tailor the patient according to, or tailor their treatment accordingly. If let's say their pressures are still high, and if you keep on increasing, so if a percentage means the symptoms which might get exacerbated by the type of disease which might be present, that is important. That is, if let's say patient is already having fluid overload and we keep them on calcium channel blockers, which either nifedipine or sometimes even amlodipine, they might have slightly the edema might just keep on increasing. Then patient will start complaining that they're not it hampers their wearing of their clothes properly or wearing of feet properly. If they're wearing of their shoes properly, if they don't wear their shoes properly, there is always a possibility they might have some injury, and that might again lead to some cellulitis or some sort of infection in the legs. So apart from that, again, as I said, if the GFR keeps on dropping down, creatine keeps on increasing, some of the medicines we need to avoid. Of either it can be ACE inhibitors or ARBs, or sometimes the patient is on oral hypoglycemic agents. We need to do keep those medicines which are having shorter duration of action. So the previous medicines like glimepiride or glibenclamide, nowadays they are not being used. Slightly lesser medicines we are going on using. Then what we need to do is to manage, see that they have a better quality of life or at least improved quality of life. So managing the CKD early and effective can definitely slow down the progression of disease and reduce the symptoms and improve the overall quality of life. Regular symptoms checking helps us in maintaining the optimal health and well-being. At the same time, we need to also counsel the patients the moment their GFR drops down to 30 or so. We need to explain them that there is possibility that you might land up in dialysis. So the possibility that you might land up in dialysis is always high. So it's always better that you need to be prepared for dialysis. That is, if GFR means creatinine has increased to somewhere near 4 or 5, we need to plan for dialysis in the immediate future. That is, planning up for going ahead for a fistula. So AV fistulas also we need to plan it up. If let's say diabetic patients are present, or sometimes they don't have adequate veins which are present, then in those events we might have to explain them the best option is to go ahead for directly transplant itself if possible. If not, then probably at the stage when the present in a condition wherein the patient requires dialysis, then probably the best option would be to go ahead for directly dialysis with a tunnel catheter. Dialysis catheter itself, we can do it. So what I would say in the last of this talk would be we need to remember that regular symptom checks definitely play a crucial role in CKD management and by enabling early detection, preventing complications, and optimizing treatment plans as well. Improving the quality of goal and empowering patients should be our goal, and preparing them for the future needs is also very important. Make sure to stay proactive and work closely with your healthcare team to manage chronic kidney disease. Thank you.